Good morning. My name is Elena Cabrera. I'm director with Folsom Cordova Unified School District. I have the pleasure of introducing our panel members today. And these are examples of leaders out there who are definitely working in cross-system collaboration. And we know that's integral. Of services to be successful, we do depend on shared resources and the expertise of the educators, the service agencies, and the legislators. It does take that team. Recently, I had the opportunity to participate in an AXA event presented by Dr. Pamela Cantor, who is with the Turnaround for Children. And she indicated that trauma is esoteric. And it made me think it absolutely has a lot of layers. If it's real in the mind, it's real in the body, and how we all respond to trauma comes out in many ways. And today our panel members are going to speak about the services that bring together the whole child, whole community supports. We have Nicola Parr, Senior Director with Solano County Office of Ed. She is a true advocate for putting students first, students' needs first. We have Tracy Lacey, also with Solano County Office of Ed. She's a licensed marriage and family therapist. And then after the two of them present, we have from Ventura County, Mr. David Swanson Hollinger, who's a senior manager with Ventura County Human Services Agency, Children and Family Services. Thank you, and I'll turn it over to Ms. Nicola Parr and Tracy Lacey.
Hi, good morning, everybody. My name is Tracy Lacey again, and actually a quick little correction. I'm with Solano County Behavioral Health. I'm a senior manager and the MHSA coordinator, and my colleague here, Nikki, gotta unmute yourself.
I am unmuting. Yes, Nicola Parr, senior director with Solano County Office of Education.
Nikki, we cannot hear you very well, just giving you a heads up as you get ready to go later.
Okay.
But we want to thank you very much, the Breaking Barriers Planning Committee, for inviting us to share our journey with implementing Solano County School-Based Wellness Center initiative here locally. So why school wellness centers? So really the truth of the matter is that we listened to the youth voice. So in 2017, Solano County Behavioral Health, in partnership with our Solano County Suicide Prevention Committee, embarked on a very comprehensive community program planning process to develop a countywide suicide prevention plan. We held focus groups and community forums across Solano County. 3 of the focus groups were with youth, including one group with our local LGBTQ center. The theme that came out in the focus groups and also in our meetings that youth attended was the need to have a safe space on campus that young people could go to what they called chill, but really what they were describing was a place to go to decompress if they were feeling stressed or if they were feeling overwhelmed. They also indicated wanting to have peers in that space as well. So we really listened to what they had to say, and that was like a seed that was planted in a garden. So kind of along that same time frame, Solano County Behavioral Health was starting to work more closely with the Office of Ed, with Nicola and her team. And what we were doing was implementing our MHSA prevention and early intervention funded school-based mental health services. And so in doing that and meeting with the school districts, we learned a lot about SCO's initiative with the districts to train them on positive behavioral interventions and supports, the PBIS framework. And the pyramid tiered system, where tier 1 is the systems and the supports that should be available to all students. So kind of gets us thinking again about those wellness centers and spaces for young people. And then an opportunity came across our paths, and that is our Solano County MHSA Innovation Project, the interdisciplinary collaboration and cultural transformation model. So this is a project that we've been delivering in partnership with UC Davis Center for Reducing Health Disparities, 3 local CBO partners, and the community. The project is focused on addressing health disparities for 3 priority populations that are underserved in Solano County: the Latino, Filipino, and LGBTQ communities. So part of this project, the first year, UC Davis did a comprehensive health assessment, really focused on those 3 priority populations. They provided us 3 narrative reports. I called them the report cards, and really told us, kind of gave a picture of what we needed to do to change our system. This project with UC Davis is anchored in the culturally and linguistically appropriate service standards and in community engagement. And so what UC Davis did was they took the information gathered during the health assessment, and they took the class standards and they merged those together and created a Solano specific training. Then we identified partners from multi-sectors, so educators, law enforcement, behavioral health providers, folks from the faith community, consumers, family members. They all received this training from UC Davis. And then they were broken up into smaller groups and they were tasked with creating quality improvement action plans. And that really was the precipice for us to be able to push this idea forward. Oops, there we go. So how we did it is, again, this idea of shared leadership and partnership. And so in addition to us working very closely together, Solano County Behavioral Health and the Office of Ed, we are working closely with the school districts and also shared leadership principles with the communities. So again, feedback loops with the community, going back out and getting their feedback around how can we make a change and make a difference. We did identify 5 school sites that we could pilot wellness centers. One of them was the Dixon Unified School District has been a partner for us all along, very involved and interested in doing behavioral health services and strengthening their supports for their students. So we piloted at 3 elementary schools in the Dixon Unified School District. We also piloted at Golden Hills Adult or Alternative Ed site, which is operated by the Office of Ed, and then Vallejo Adult Education site. So these pilots allowed us an opportunity to kind of sort out how would we implement this, how would we, what supports would we put in place, what was going to be needed in order to be able to scale this up on a much, much larger scale. So we developed a grant application process. School sites applied. We went out and visited each of the sites, had an opportunity to talk to the administration and the key stakeholders at those sites, to talk to them about this project, where it came from, why we were doing this. And we also were able to view the spaces that they were proposing to use. And then probably most importantly, and I'll dive into it more in the next slide, is we really worked to conjointly leverage different funding. So rather than competing with each other for grants, when we found out about grant opportunities, the Office of Ed and Behavioral Health, we call each other and say, hey, does this seem like something that we could do together to address this need that we have or enhance what we're already doing? So we work really hard on partnering on this. So funding sources, how we were able to pay for this, we had some MHSA innovation reversion funds that we were able to use. So you can see about $960,000 was used to pay for the startup furnishings and wall hangings and supplies and all the gear that we would need in the wellness centers. We also continue to use MHSA PEI funds to help support the systems and the services that are going to be scaffolded into the wellness centers. And then SCO was able to receive a California Department of Education grant. This grant was used to kind of help plan the very beginning stages. They were able to work with an attorney to learn more about HIPAA and FERPA, and also started to explore an electronic health record. And then the County Medical Services Program, this is a grant that allowed us to expand this actually to adult education sites. And then of course our partners at Kaiser came forward too as well to offer a grant to help support this effort. So I'm going to go ahead and pass it on to my colleague here, Nicola, and she'll take it from here.
Thank you, Tracy. Can everyone hear me?
You're faint.
Okay, well, I'll try to get closer to my speaker here. As Tracy had mentioned, I was selected to participate in the class project facilitated by UC Davis and was a part of a team that was developed called Taking Class to Schools Action Plan. And the group included the Adult Education Consortium Manager, the assistant director of the SELPA, and a K-12 mental health clinician. The members of the team collectively had experience in K-12 education, special education, and adult education. And our group was tasked with developing the action plan that addressed a need within our community based on recent stakeholder data. And as a group, we worked through the process and an area of focus emerged, which was centered on improving access to mental health services by co-locating services and service providers in local schools. Having been a part of the ongoing stakeholder engagement activities facilitated by the County Office of Education, County Health and Social Services, and particularly the County Suicide Prevention Committee, I had heard many times the call for school-based wellness centers, and this was coming primarily from youth. It was also clear that the community at large was calling for increased and improved school-based mental health services. So the team developed an overarching goal based on the class standards with an emphasis on reducing barriers for underserved communities to improve access to culturally and linguistically appropriate services. And at that point, the School-Based Wellness Center initiative was sparked. As Tracy had presented, SCO partnered with Solano County Behavioral Health, and we really did support each other in the grant writing process. And we constantly looked for opportunities to braid funding. Each site was developed based on feedback from students. Focus groups facilitated in K-12 schools were supported by Solano Youth Voices, which is a youth-led group focused on youth engagement and advocacy. The picture on this slide is of the Vallejo Adult Education Wellness Center. A graduate student from UCD facilitated the focus group at the Vallejo site. Students were provided an overview of what a wellness center is, and they were asked questions to help determine how they wanted the room to look and what type of programming they wanted to see in the centers. And additionally, overview presentations were provided, focus groups were provided to parents, teachers, and administrators to gather input from them concerning the design of the wellness center. So we wanted to have a robust stakeholder process and really ensure that we were including many different voices. To date, the initiative has funded the establishment of a total of 35 wellness centers. Next slide. Our theory of action is if schools open wellness centers that are easily accessible to students and provide culturally responsive supports and services, then we will see improved student outcomes in the areas of academic achievement, social and emotional competence, increased pro-social behavior, and resilience. We worked with school administration to select an appropriate location on campus to house the centers that all students have access to. The Wellness Center philosophy includes several elements. And first, all students are introduced to the Wellness Center. Each student should be given a tour to provide information on how to access the center, activities they can do, and services that they can receive. The goal is to normalize visiting the center as a regular part of their school day if needed. The centers must be calm and supportive environments for students needing a place to recenter and recalibrate. School staff must be trained in trauma-informed practices that support better understanding of the need and value of the center. Emphasis is placed on mental health stigma reduction and wellness messaging. The center should act as an access point to link students to a continuum of behavioral health services, including suicide prevention. And peer-to-peer delivered services should be offered when appropriate, such as sources of strength or another evidence-based peer-to-peer model. Next slide. Staffing the wellness centers has been an area of focus. School administration expressed concerns about how to staff the wellness centers when they do not have the ability to hire additional staff. That was a really big concern for them. During focus groups, the youth identified the need for a caring adult and not necessarily a clinician. This is why we emphasized expanding school staff training to include paraprofessionals, such as campus monitors, cafeteria workers, transportation staff, and not limit training to teachers. We have also worked to begin to build a group of volunteers in the community who can support wellness centers once schools reopen. We have reached out to retired school staff and the faith community. A faith and education collaborative was started in December to bring together different faith organizations and educational leaders to focus on training those interested in volunteering with models or training curriculums such as youth mental health first aid, and as well as training on how to be a mentor to prepare them to support the centers. Peer-to-peer support programs are being identified, and we have recently contracted with several universities to create a clinical intern program. University MSW and MFT program interns are providing services in the wellness centers, including virtual wellness centers during school closures related to COVID-19. During the focus groups, participants identified how they wished to have the services delivered. Based on feedback from stakeholders, student workshops were created that address a number of different topics that are available to all students. School clinical staff are provided training on how to make linkages to community mental health treatment services. Educational groups are offered to students on topics such as suicide prevention, nutrition, substance use prevention, and wellness. We are working with county public health to coordinate dental and medical services through the county mobile van. Finally, school-based wellness center resource fairs and the distribution of mental health materials supports efforts to continue community awareness about mental health and wellness. And in the future, we will be coordinating services from community agencies and partners to support co-location of services that expand support for students. Next slide. We want to thank you for your attention. Our contact information is available, as well as a link for a film that we created to memorialize this project. And we are now open to questions that you may have.
We can't see the chat, but I think other folks are going to help us.
Yes, there's a question here from Mendocino County. How do you secure ongoing funding to these centers?
So part of what we're doing is we're scaffolding in services that are already funded through MHSA Prevention and Early Intervention. So we already had several contracts for school-based services. We also have deliverables and contracts through our LGBTQ Center to do Welcoming Schools model, through our NAMI contract to do in our own voices presentations. So we're leveraging those services. The schools also are bringing forth their funding that they have in their is it LEAs? What is it called? LCAPs?
Elliot.
So that's kind of how we're continuing to fund it. I don't know if you want to add anything else, Nikki.
Well, I think what we discovered through this process of collaboration is that we have a lot of services available. They're just not necessarily coordinated. I had, when I would attend MHSA funded or sponsored events, I would have directors of community-based organizations saying, I have funding, I would like to get into schools, and it's difficult to just pick up the phone and be able to talk to a principal and walk in. You do need to have someone coordinating those services. And so we're finding that that's where we're going to have to lean heavily, because no one entity has ongoing funding, and grants are wonderful, but they're time limited and are not necessarily going to continue to fund all of our programs in the future.
Thank you, Nicola. There's another question here from Timothy Hogan, and his question from San Bernardino County Behavioral Health is, any discussion of billing Medi-Cal?
Not at this time, but potentially in the future. So one of the things that the youth said kind of unanimously is they did not necessarily want therapists staffing the centers. They want a caring adult, and they want to be able to be referred to a therapist if that's what they need. So the centers are really being staffed by kind of just any adult that's appropriate, that has some training, and it's a place that kids can go for 10 or 15 minutes, decompress, and go back to class. If they need more services, they'll absolutely be referred.
Great, thank you. There's another question here. What were the learning objectives relative to the use of innovative funds?
That's a great question. So part of our objectives for the overarching UC Davis, the Cultural Transformation Model Project, really is around increasing access for our underserved communities. So what we've done is we've created these wellness centers that are culturally responsive. So all students are welcome. Lots of efforts around making sure that the imagery in the rooms represent all people, including our LGBTQ communities. So we are collecting data, and we only have the 5 pilot centers opened before COVID hit, and now the schools are closed. So we are still in the implementation process at this point.
Excellent.
Full of time. Is it time for us to switch over?
Do we have time for one more question, Jamie? I'm going to go ahead and ask, and then we'll switch over. And this is from Victoria Zimmerly. Do you have any initial outcomes from the pilot?
We do have some outcomes around the usage of the wellness center, the initial 5 wellness centers. And again, a lot of this was a bit derailed when COVID hit. And now we are starting, as Nikki mentioned, to do some virtual wellness centers. So we'll be collecting data on how many students are accessing those virtual portals. And all of this will be reported out in our innovation. Our final evaluation report will be done a year from now at this point. We end this project in June, and the final report will be published in next October.
Fantastic, thank you. And we're gonna go ahead and move on to our next presenter from Ventura County, Mr. David Swanson Hollinger. And here we go.
Okay, let me find my presentation, which of course has...
This is an opportunity to remind the members joining as participants that these questions will be collected and put into a Q&A. So if you don't get to all of them, and at the end of the presenter sessions, we'll have a couple of minutes to respond to some more questions on both presentations.
Okay, sorry, I was having trouble finding the presentation. Seems to have disappeared, but I think we are good. Are you seeing it as a full screen, or are we still seeing my notes on there? I want to make sure I'm doing this correctly. There it goes. Okay, thank you, and love that great work that's happening. I am David Swanson Hollinger, and I am a senior manager with Ventura County Human Services Agency, Children and Family Services Department, and I'm excited to be here. Love that we are still having a virtual conference. I know last year's in person was outstanding, so this is exciting. And as I indicated, I wear a public child welfare hat, but I'm really here to talk about some of the work we're doing in Ventura County to look at a more structural approach to, I'm going to use prevention in quotes, which I'll talk about in a minute, and around our larger systems work that we're doing in our county to support families. So this will be more of a macro perspective to that. And there we go. Okay, so I want to start with providing some context of how we in our county look at the phrase prevention. And we, first of all, within child welfare, we talk about in Children and Family Services, the idea of protecting children by strengthening families, that foster care is not the answer, that children really belong with their families to the degree possible. And in that vein, our system in public child welfare is very reactionary. We come in late, we come in after families have experienced significant challenges, trauma, both for parents and children, and after the allegations are already present at the very least, and often abuse or neglect has happened. And so we want to really move upstream to look at prevention in a different way. In the context that prevention is not something separate from child welfare, which often it's been organized and set up as something different than the public child welfare mandate, but it's really part of our broader continuum of care. And I started off by saying prevention in quotes. I'm frankly not a huge fan of that because I also wear a public health hat and I've worked in a lot of other systems. And really, when you look at prevention, it's about promotion of child and family well-being across systems. And it's that system, that broader system, that I want to talk about, looking at those social determinants of health, those factors that really impact families in both positive and challenging ways, with the idea of prevention across all systems comes from building resilience to address those drivers, those factors that lead to those stressors in families, that lead to those you know, in the child welfare term, those safety concerns or those safety threats. So it's a much bigger perspective that we're trying to look at within our county. I'll talk a little bit about what we call in Ventura Essentials for Childhood Ventura County, or our fun new acronym we've started using, E4C-VC. And Essentials for Childhood is a Centers for Disease Control model. And essentially it's strategies to promote relationships and environments that help create neighborhoods, communities, and a world in which every child can thrive. And I wanted to quote that because it's straight from the CDC. This evolved out of a couple of things. One was a statewide prevention summit that was hosted by OCAP, I guess going on 2 years now in January, which was a cross-systems look at bringing in systems at the county systems and county groups across multiple systems that touch families, multiple child serving and family serving systems. And what we've done with this, instead of making this about prevention, child abuse prevention per se, we're using E4C as a foundation for that broader system of care approach, for a child and family well-being system that looks at how child and family serving systems across those broader continuums. It will be the foundation for our family first planning. It will be a way to look kind of at the sense of when you talk to different systems, and I'll give an example. When I was in a meeting early on, I think prior to the initial summit with a number of my education partners, and we were talking about the factors, the stressors on families in their system. One of them got up on a board and drew a pyramid. I realize my face is covered here. Drew a pyramid up on the screen, and it was a prevention pyramid. And the factors, the fundamental factors that impact families were essentially the same as what we talk about in child welfare or public health or behavioral health or early childhood. And yet the outcomes that they might be looking at were educational outcomes, or they might be early mental health outcomes, or they might be early childhood outcomes. But going back to, as we work with our partners, we really are trying to strip down what's in it for them. What is it that ties to the mandates and the vision of what our partners do? And that's really been the way we've tried to frame this. I think the other big piece of this is that this is fundamental in looking at disproportionality and disparate outcomes within our system, and at race and equity challenges within our system. We did some work several years ago that came out of our work as a citizen review panel, where we did some geographic assessment within our county to look at where our referrals are coming from into child welfare. And we found that about half of our referrals were coming from several zip codes in a certain part of our county. And as we dug into that, we looked at, this is an area that is definitely stressed economically and socially, but in a similar way as other kinds of areas as well. But then as we started digging deeper and pulling in our partners, we realized that in talking to our other partners that same factors were disproportionately impacting those systems. So behavioral health and First Five and childcare and public health all dug in and looked at what are some of those stressors and what are some of those data elements within that system, and doing geomapping. And it's allowed us to, within that area, kind of dig in and look at how do we do community building and how do we provide some community support in that area, and look at how we do our work differently across our systems in that area going forward. So that was one of those foundational elements to E4C as we've moved it forward. Membership within this group, you can see there on the left-hand side, there are the 5 partners in green, and I'll talk about this in a minute, but those are those partners that are mandated as part of the AB 2083 legislation. Human Services, Behavioral Health, Probation, Education, and Regional Center. But there's also a number of other partners that are listed there that you can see, and really looking again at cross system. This group is still being developed, and we are still expanding membership. We last meeting brought on someone from our medical managed care entity, which was a wonderful addition, with healthcare being so critical, and we're now looking at bringing in primary medical care as well. You can see a number of 4 different subcommittees, with the steering committee being that umbrella group that's really trying to drive the purpose of this group as it goes forward. Parent leadership, this group has been a hub as we've tried to bring together and are beginning to bring together parent leaders and parent partners and peer partners from across our various systems into a unified body to coordinate and better align the work across these different systems. Capacity building is another area where we're using the group to dig in and look at where do we have strengths and assets within our system to support families and where are those gaps. That'll be essential as we move forward with Family First in the upcoming year. And then data. We have a data group that's trying to look at that age-old challenge of how do we take data and share it across systems, look at data in a way that is coordinated and integrated to support families, both at the client services level, the family services level, but also at the more macro level to drive programming, to assess common outcomes, to use it for planning going forward. You can see here the purpose as we've identified it within E4C, aligning government, family, stakeholders to maximize wellness and quality of life. And I think the key point there is that it really is a wellness approach. It's not a prevention approach. It's a wellness and promotion approach to supporting families within their community to be safe and well and healthy. With the idea that the members are expected to, and the membership of this is essentially deputy level individuals across each of these systems, both the public systems as well as education, child care support and others, First Five, et cetera. So these are all executive or deputy level positions. Looking at how can we shift policy, how can we shift program, and how can we shift practice to align to that broader continuum. And so core to this is looking at the integrated core practice model. And as we continue to evolve that, how does that align with systems outside of the initial systems, probation, behavioral health, and child welfare that were part of the original development of the integrated core practice model? How do we look at communities to be part of building some of the networks and the supports that we do? You can see here more specific objectives, and these are all pulled directly from the charter. I didn't want to put the whole charter up to several pages, but I thought it was important to get a picture of the way this group is trying to organize and is moving forward. And the idea of effectiveness, efficiency, and equity, I think, are critical in the work that we do. That success isn't about success in one system. It's about success across all systems in a much more integrated way. And families don't live in one system, even though we often work in a siloed way. They exist, and we all experience systems in a much more integrated, holistic way. So trying to take that approach. The idea of community engagement to identify complex community problems. And that was a lot of the work that we did in the neighborhood work and the geomapping work, is both look at data, but then here we did a fair amount of work to dig in and talk to the community, hold focus groups with the community to understand how are we engaging families, how are we supporting families in those communities. And then from that, looking at where can we develop innovative ideas, innovative approaches to support families. Just a simple thing that we've done just during COVID, because there have been so many challenges, and I know in my hat in the child welfare, there's been a lot of talk about worries of families who are no longer exposed during COVID or have the visibility of those that are called mandated, the mandated reporters. And we wanted to acknowledge and look at families are stressed right now. We know that, and we didn't want to create a system of surveillance to disproportionately, find families or target families that might be impacted by that stress. So we worked with our Office of Education and our special education folks within that, as well as behavioral health, to hold a series of webinars and trainings essentially for teachers doing online learning, not focused on mandated reporting, but focused on the trauma that families are going through right now, the stress that they're going through. So the teachers who are now, especially with school back in Ventura County, it's almost exclusively online learning, so that teachers can identify and see those stressors in families before there's a need for higher level intervention, and provide them some linkages to some supports and services that they may need. So the last thing I want to talk about is how does this all tie to AB 2083? And most of you, anybody that's part of those main 5 systems, I'm sure is very aware of this. There is a mandate to create a system of care And the way the law is written, it really focuses on those children with the highest level needs. And as I indicated before, we want to look at that much more broadly, at a much broader continuum. And so we really see this as an opportunity to go upstream. And we're using E4C-VC as the foundation for that development, for the development of our broader system of care, with the groups within there, the work groups within E4C, doing some of the specific development of the elements and using the foundational elements as we start working with agency leadership, agency heads to dig in and move that forward. So we're taking this as an opportunity to go much more broadly and look at the promotion of that child and family well-being system. This is very much aligned with the work that we're seeing through the federal government, through the ACF and KC family programs, which is very exciting. And I know the state as well, as they're looking at Family First, is moving towards that broader look of a child and family well-being system with shared ownership. And in that system, child protection is one element. Often when people talk about child welfare, they think of child protection, but child protection is just one element in that broader system. So that next slide. Okay, I'm not forwarding here. Thank you for bearing with me. I'm actually at a different location with not my user technology, so I'm trying to make do here. Appreciate that. So just to summarize, again, with AB 2083, we are looking at that full continuum. E4C is that hub. The family voice is critical to that, and that's where that parent engagement committee of E4C is going to be critical, as well as race and equity and inclusion in how we're doing this. We are trying to dig in and make sure that everything that we're framing addresses both the practice as well as the structural issues within our system. We, as many counties, have a disproportionate number of families, of Latino families in our system. And we know that our system is structured in a way that doesn't always fully engage those families. And systems is probably a better phrase. And so wanting to look at how can we better serve families across those systems and address the trauma that is often inherent in those systems, both from what they've experienced in the community and racial trauma. And so that's all part of how we're digging into our work here. And with that, I will pause. I apologize for the technical challenges, but I will open it up to any questions.
Again, to our attendees, as a reminder, you're welcome to, we'll be collecting some of the questions too once the session is over, and responding in our Q&A and sharing that out.
I see one question from Richard here in the chat, and thank you for that, around engagement of the MHPBH partners. And that's been a long process that began with KDA and CCR, but I think is taking we're taking it to a different level in the last year or two. I think one real specific example of looking at that engagement is a philosophical approach that we've taken in our county. This is very concrete, but our county has taken the approach from a behavioral health standpoint that any child that is touching the public child welfare system has experienced some sort of trauma. And we've taken a policy approach that all of those children should be eligible for specialty mental health services, for at the very least an assessment and short-term treatment. And so that has been the beginning of that work, and that has led to some significant positive changes within our system: reduction in congregate care numbers, reduction in placement changes. But I think more fundamentally, it talks about how the shared ownership and feeling of how these families are really our families. The other piece that we're exploring is the behavioral health side, as you behavioral health folks know way better than I, has their own requirements around interagency policy committee work. And so we are working with behavioral health to talk about where is that intersection between the IPC, which at the county level, which consists of similar leadership and similar individuals, and 2083. And behavioral health has been very on board with that. I see from Elizabeth a question about, sorry, I'll let you moderate the questions.
Fantastic. You're doing, what was the process that you followed to get where you are? And I'm sure there's a lot of folks that want to know that.
You know, it really started with the work we did with our neighborhood work around the citizens review panel. When we looked internally within child welfare and saw that our data didn't look good, frankly, in certain counties. And we started reaching out to our partners and engaging them in dialogue about that and acknowledging, I think, that, you know, we have challenges within our system and we want your help. And so there was a level of, we can't do this alone. And that's what allowed them to start digging into some of their systems and realizing things look similar here as well. I think the other big piece goes back to framing this as not a child welfare issue. Though I'm talking about child welfare in that example, framing this as this is a family issue. This is about how do we better support families. And I think that's had a huge impact in getting people to the table so that they're not just being pulled to the table by us. It's they're coming in for their own interests as well.
Yeah, it's definitely a family issue. I think the next question you may have answered, but if you can identify what was your biggest challenge in starting out?
Boy, a number of them. I think one was just what I just talked about around how do we make this about all of the work that all of us do. And I think part of it is, you know, and we talk about this at the practice level, and there's a very specific case I'm dealing with right now at a very high level that child welfare doesn't have to drive everything. And so for us, it's been step back and try to find that balance of wanting to be a catalyst, but also wanting to support our other partners and stepping up and sharing the leadership in this.
Thank you, David. There's a couple more questions, and we're going to be wrapping up in about 3 minutes. I'll take Melissa Jacobs's. Is the focus on prevention that was initiated by the Prevention Summit for all ages of youth?
Yes, yes. We like many counties have within child welfare, a disproportionate number of children in our system who are 0 to 5, and probably 60% of those children entering are under 5 years old and from families, you know, of young children. But absolutely, it's a full age continuum.
Fantastic. And I want to elaborate. I have to correct something. We are able to take questions up until 10:35. So whether it's for David or Nicola and Tracy's presentation, please feel free to ask any questions and we'll do our best to respond. There's a question from Richard. It says, can you, if possible, elaborate on how your school education tier 1 prevention work connects to your prevention work, to your prevention coalition work?
Sure, and I think this is the area that is probably both that and working with Regional Center has been the area where we've needed to grow the most. We've had a very healthy partnership with probation and behavioral health and actually public health for a number of years, and done a lot of cross systems work around through CCR and KDA. Education, we've always had some level of partnership, but we're just beginning. And I think that example that I gave around the work with teachers and the training was a good example where we're trying to shift that mentality where this is also some shared responsibility across systems. And so that is an area where we're just beginning to dig in with our Office of Education and leadership from there to better partner. Regional Center as well has come to the table in a very powerful way in the last several months, which has been extremely exciting. It's been an area where we haven't done a great job of engaging them across any of our other behavioral health or probation or child welfare systems.
Thank you, David. And I'd like to see if Nicola or Tracy can elaborate on or chime in on that question as well. Related back to the Prevention Coalition or the prevention work and how that connects.
You want to talk about tier 1 supports?
Here.
So we are a county that has trained about 80% of our schools in positive behavioral interventions and supports. And at the tier 1 level, we're looking at universal supports for all students, both academic, behavioral, and social emotional. And so what we have done in terms of collaboration is working with our partners on training them in the PBIS model. So there was times where Tracy and I got together, I shared my slides with her and kind of explained to her where we are going in education. And she says, well, wait a minute, we're doing the same work. We're using a lot of the same terminology. We're serving the same students, the same families. How can we work together? And I think that was one of the sparks of our ongoing and continuous collaboration. How can we support each other? Where are our shared goals? And what is our vision for our organizations, and how can we continue to collaborate better?
And if I could just elaborate to the Tier 1 supports in using wellness centers is just, it's teaching wellness and stigma reduction for all students. I'm not sure if we mentioned during the presentation, but when we open a wellness center, all the students get to go to the wellness center to see the space, to demystify it, so that young people know that it's a place that they can go in, and then it's an access point if they need additional services. So it's really meant to serve all students. And then we will be providing trainings and workshops for parents as well, and school personnel out of the wellness centers too.
And to Tracy's point, we actually hold ribbon cutting ceremonies. So the entire community comes out. We have, the superintendents from the schools, our county superintendent of schools, public officials, folks from all of the different sectors within public health and behavioral health. Mm-hmm. They're all there to witness it and to celebrate it. So it's truly a celebration in our communities.
Well, that cross-system support is integral for sure. A question from Melissa Jacobs is for Solano. How directive was the County Office of Ed with the district schools to participate in the wellness centers?
Well, this was totally voluntary. We put it out there. We went out, talked to them, let them know that this was an opportunity, but we did not force anybody to do this. So everybody had to come forward. They had to have district leadership support. And that's really how we went forward with doing this.
Fantastic. And also such thoughtful and focused work in Solano schools. Does your Child Abuse Prevention Council know that of your significant efforts and progress in this area? They'd likely be super interested to see how you're impacting child abuse risk.
Yeah, so there's lots of different partners in Solano County that are very aware of this initiative. We've done lots of press releases and ribbon cutting ceremonies, etc. And because I work in a super agency, Health and Social Services, the intent is to not just scaffold in behavioral health services, but also to bring our child welfare partners in for them to do prevention work. So David, I love the work you're doing. We're gonna have to have a phone call, a Zoom cup of coffee, the three of us. But yeah, bringing in public health, their dental van, employment and eligibility to go out to help parents get signed up for insurance and assistance. So this is really, these centers are meant to be kind of a one-stop shop for families, and absolutely child abuse prevention is key.
There was a comment earlier about connecting the prevention dots with the dollars, and that could not be more accurate. You three have really connected those dots, and let me tell you, they're not easy to connect. And you have set an example. There's a question here from Dan Sackheim, and I apologize. You certainly can correct me on that. I would appreciate it. The California Department of Ed, have you also provided training in your youth mental health first aid?
Absolutely.
Yes, hi Dan. They're definitely providing training. We have a group of trainers, and we have been conducting youth mental health first aid. We had our first cohort actually last summer. We went through the train the trainer model, and with COVID-19, there has been a shift that we're going to have to make and offer those trainings virtually, but absolutely. And it's going to be an integral part of training the faith community, those faith leaders that are stepping forward saying that they want to support the Wellness Center initiative. They will all be trained in youth mental health first aid.
The Office of Ed staff also were trained in ASSIST and Safe Talk, 2 suicide prevention curriculums. They're also trainers there. So part of the Wellness Center grant and kind of agreement is that they have some of their staff trained in all 3 of these curriculums, and then also in how to access the county behavioral health system of care.
How about Ventura County, David? Could you add to that?
Yeah, I'm not the one. It's been done through MHSA for a number of years. We've done MHSA through our MHSA dollars as well, and not sure where it is currently, but I know that's something that we've had a very robust. I used to be over there in that hat 7 or 8 years ago, so it was happening as I was leaving, and it has been a very fundamental. And mental health first aid has been a fundamental part of the work that they've done through the PEI dollars and MHSA.
Well, I would like to thank our panelists. We are running out of time, and really thank you so much, David. and Nicola and Tracy. Fantastic information. It's exciting. I know our county office, whether it's health, ed, we definitely need to work together on these efforts, and you have set an example for us to follow. What we're going to do is we're going to take a quick stretch break. On our next sessions, we will begin at 10:45. That's in 10 minutes. If you want to join the facilitated breakouts, follow the directions posted on this session. If you want to join the deep dive, click to that session, and the live stream will start at 10:45. Thank you all so much.
Thank you. Have a good day, everybody.
Take care, everybody.